Okay, so just like autism, gender also falls on a spectrum. And while sex refers to biological and physiological characteristics, gender is a socially constructed role of which biological sex is only a small part. And there is some emerging evidence that the rate of gender nonconformity is higher in the autism community than the general population. Throughout its history, autism has maintained a male to female ratio of between 4 to 5 to 1, with the most current estimates of 4.5 to 1. So why this prevalence difference? There could be genetic or epigenetic effects like X inactivation in females. Environmental factors like in utero testosterone, stress hormones, or infection may also contribute. Another is this self-fulfilling prophecy that more males are diagnosed with ASD, leading to research being biased toward males, leading more males being diagnosed with autism. Recruitment of females has been a major challenge for autism researchers, and in fact, some studies only include males. So which one is it? Just like ASD is not caused by just one factor, it is unlikely the prevalence difference between the sexes has just one explanation. It makes sense that males have an inherent genetic susceptibility and therefore have more severe autism. However, the exact opposite was reflected in early literature about sex differences in autism, which we will now discuss. So historically, females with ASD were thought to have more severe autism symptoms, higher rates of intellectual disability, and higher rates of seizure disorders. This is partially due to the fact that older research was done using different diagnostic criteria, which tended to diagnose only the lowest functioning individuals. We now know that the male-female difference in ASD is much more nuanced. Even with narrowed phenotypic variability among the sexes, the male predominance remains. So why is that? It is thought that females with mild or high-functioning ASD are better able to mask or compensate for her difficulties, leading to milder presentation and later diagnosis. Cultural influences regarding gender conformity also certainly have an impact on the developing child. And since ASD is less common in females, clinicians may first diagnose ADHD, mood disorders, OCD, or an eating disorder. Moving on to typical development, we know that there are differences between the sexes in early childhood. Females on average have superior verbal and social skills, and males tend to have strengths in visual spatial tasks and physical strength and endurance. So how do these differences manifest in ASD in early childhood? Projects looking at sex differences in ASD are often plagued by small numbers of females and lack of typically developing controls. So we wanted to look more closely at these differences. I was graciously granted permission to analyze data from the CHARGE study. CHARGE stands for Childhood Autism Risk from Genetics and the Environment. Children with autism or developmental delay are recruited from the California Department of Developmental Services Regional Centers, and then age and location match typically developing controls are recruited using birth certificate data. To be included in the study, children had to be 24 to 60 months old, born in California, speak primarily English or Spanish, and live with at least one biological parent. The assessment includes comprehensive in utero and early life exposure histories, medical history, and physical, developmental assessment and collection of any available biologic sample. The developmental assessment consists of the Mullen scales of early learning, the Vineland adaptive behavior scales, and the aberrant behavior checklist. Children with ASD undergo the ADIR and ADOS, and the parents of children who are developmentally delayed or typically developing complete the SEQ to screen for symptoms of autism. A child is considered typically developing if he or she has a Mullen early learning composite score of greater than or equal to 70, a Vineland adaptive behavior composite of greater than or equal to 70, and a raw score on the SEQ below the cutoff of 15, which can be substituted for any clinical concern for autism. And of note, the Mullen and the Vineland both have a mean of 100 and a standard deviation of 15. So moving on to my project, my aim was to explore developmental and behavioral sex differences in autism spectrum disorder using the CHARGE study. Thinking back to our previous discussion, I hypothesized that males would have more severe autism symptoms than females. I also thought that females would outperform males in typical development due to early developmental advantages, and that this would extrapolate to the autism group as well. For my analysis, we elected to include children who met criteria for autism on the ADOS and ADIR, as well as their typically developing controls. We excluded any participant with a known genetic abnormality. So if you will see here, just keep these patterns and colors in mind. So the blue pattern is the ASD male, pink pattern ASD female, solid blue typical male, and solid pink typically developing female. And note that the male to female ratio for ASD is about 5.5 to 1, which is similar to the 4.5 to 1 quoted earlier. So using ANOVA and chi-square to look at demographics, there were no significant differences across groups in age, race, ethnicity, maternal education, paternal education, or highest household education. However, there was a trend towards differences in age and maternal education, so regression models were used to explore main effects and interactions. Using linear regression, we found that there was a main effect of diagnosis on age without any sex or interaction effects. So basically, that just means that the age was different between the two diagnostic groups. So on further analysis, we learned that the ASD children were older than the typically developing children by 1 month. And while this is statistically significant, there's obviously minimal clinical significance to this finding. Using logistic regression, we also found a main effect of diagnosis on maternal education, again without sex or interaction effects. A simpler way to think about this is that mothers of typically developing children had higher levels of education than the mothers of children with ASD. T-tests to use were look at sex differences within the ASD group, and we found no significant differences in age at diagnosis, ADOS module administered, ADOS comparison score, ADIR scores, or enrollments in therapy. So the first outcome measure is the Mullen scales of early learning. The developmental quotient was used, which assists with improving the accuracy and variability of the lowest scoring individuals, which would otherwise be impacted by what is known as the floor effect. And the second outcome measure is the Vineland Adaptive Behavior Standard Scores. Linear regression was used to examine main effects and interactions with sex and diagnosis as predictor variables. Age was not used as a covariate, as all the scores had already been standardized for age and the sample was matched on age. But maternal education was used as a covariate because it's tightly correlated with a child's cognitive and language skills, and there were also some differences at baseline. Moving on to the results, there was a very significant main effect of diagnosis for all scales and subscales, with the typically developing children scoring higher than those with ASD, which we expected. So here are the Mullen scores. So you'll note this hash line is the mean of 100, and the main effect of diagnosis that I was talking about, you'll see is just that the typically developing kids are outscoring the children with autism, which again, we expected. There was also a significant sex effect. So that just means that the females were actually outscoring the males across all scales in both diagnostic groups. But there were no significant sex by diagnosis interactions. So this is for the Vineland, and again, you'll see the differences between the typical children and the children with autism. And there was a main effect on all of sex on all subscales and the composite, except for motor skills. And this sex effect indicated that females were outperforming males, but this did not hold up for both diagnostic groups. There was actually a significant sex by diagnosis interaction in daily living, socialization, and the composite score. So that just shows that the sex effect is really being driven by the typically developing, in this one, male and female difference, but the kids with autism the scores were more comparable. So in summary, in this sample, males and females had similar age at diagnosis, symptoms, and rates of participation in therapy. These results contradict the historic view that females with ASD were lower functioning than males. This would also lead me to reject the hypothesis that males would have more severe autism. Females outperform males across both diagnostic groups and developmental functioning, which supported my hypothesis. Typical females also outperform typical males in adaptive functioning. So the cognitive advantage of autistic females does not necessarily translate into better adaptive functioning. We know that cognitive and adaptive skills are highly correlated, and the sample did not reflect that in the females with autism. So while there were some statistically significant differences, there are minimal clinically significant differences, but there are some important clinical implications. So if females are not meeting their adaptive potential implied by a developmental advantage, then what can be done? First, we need to figure out why this is the case. Once we learn why, then we have to ask ourselves whether we can treat the deficit. And if it can be treated, then we have to learn how. As always, research raises more questions than they deliver answers. So long-term goals would involve improving recognition and diagnosis of females with autism, increasing representation of females in research samples, considering sex-specific diagnostic and treatment pathways, and examining the interplay between culture, gender, and development. So I'd love to thank all of my wonderful mentors, the section of Developmental Peds, the Mind Institute in general, wonderful co-fellows, Charge and the IDDRC and MCHB. It's just been an awesome 3 years. I've enjoyed being here so much. I've learned so much from all of you. And it's really just been my pleasure getting to know you all. And I appreciate everything you've done for me. Everyone's just been so kind and welcoming. And I'm really going to miss everyone. So
it's great to be here today to talk to you all about the study I've been working on the past couple years. I have nothing to disclose, and we'll get right into it. So we'll start off with some background and significance. So as many of you know, ADHD is a very common and impairing neurodevelopmental disorder, and symptoms often emerge in the preschool years, and many of those children will go on to have symptoms into elementary school and beyond. And in terms of treatment in this age group, behavioral therapies are recommended as first line. In reviewing the literature on yoga as an intervention for children with ADHD, I found some small but very promising studies looking at school-age children and seeing some benefits from yoga. But when I looked for studies in preschoolers, I wasn't finding anything. And so that was the impetus for this study. So the objectives of the study were to assess the feasibility of having preschoolers with ADHD symptoms do yoga, both at home and at school. And I also wanted to determine the ability of our outcome measures to detect changes in those symptoms after practicing yoga for 6 weeks. So this is the theoretical model that I used when I was creating the study. So it focuses on that yoga improves body awareness and self-regulation. And in adult studies of yoga, there have been some results showing that yoga can improve vagal tone, which can be measured non-invasively through heart rate variability. And increases in heart rate variability are thought to have association with self-regulatory capacity. So I included that as a potential mechanism for improvements in self-regulation. So that combination of self-regulation and increased body awareness then leads to improvements in attention, the ability to focus, and control over one's actions. And I hypothesized that that would lead to a decrease in ADHD symptoms. And I aim to measure that by looking at parent and teacher rating scales, as well as two more objective measures. One was the key tap, which is a computer-based task of attention, and the other was heart rate variability. So the study design was a randomized waitlist control trial. I was able to recruit 23 children from a local preschool, and all of the children included were between the ages of 3 to 5 years old, and they had to have at least 4 or more ADHD symptoms in order to be included. And the reason we chose that as inclusion criteria rather than a diagnosis of ADHD is because often ADHD isn't diagnosed in this age group yet. And we really wanted to look more at symptom change with the intervention. So the intervention itself consisted of 30-minute both home and school-based yoga sessions over the course of 6 weeks. The school sessions were held twice a week at the preschool, and they were led by trained children's yoga instructors using a manualized protocol. And the home sessions were done on the days that the children didn't practice at school and used a yoga video that featured the same protocol as the children were learning at school. So this is just a look at the study timeline, and the study included both quantitative measures as well as qualitative measures. And today we're going to be focusing on the quantitative measures. So after we recruited and randomized the children, we did baseline testing on everyone with the quantitative measures. And then the first group did yoga for 6 weeks, while the waitlist group just continued with their regular activities at school and at home. And then we repeated those quantitative measures at post-test 1 on all of the children. And then the group switched. And so the children that had been doing yoga went back to their regular activities, and the waitlist group did yoga for 6 weeks. And then we repeated those measures at 2 more time points, at post-test 1, and then 3 months after that at follow-up. And so what I'm going to be presenting today is just our primary analysis looking at the yoga group compared to the waitlist group. So just a quick look at the demographic data between the groups. There were no significant differences for the children. And similarly, for their parents, there were also not significant differences in terms of demographic data. Getting a little bit into more detail regarding the methods that we used in the measures. So we used 2 different parent and teacher rating scales. We used the ADHD rating scale preschool version, which has an inattentive subscale and a hyperactive impulsive subscale, so really looking at solely ADHD symptoms. And then the strengths and difficulties questionnaire is a broader questionnaire that has 5 different subscales, one of which is an ADHD combined symptom subscale. The key tap, as I mentioned before, is our computer-based task of attention, and we use the 4 subscales that you can see here, so one of which was a go, no-go task, and it was done in a very child-friendly manner around the theme of an enchanted castle, so to help engage the kids in the activity. And then while they were doing the key tap, we also measured their heart rate variability. So they wore a little monitor on their earlobe that measured the beat-to-beat changes in heart rate, and that was our way of measuring their self-regulation. In terms of analyses, we use between-group comparisons of the mean outcome levels after the first 6 weeks of yoga, and we used mixed effects linear regression models to adjust for baseline when available. We also looked at the dose of yoga that the children were exposed to over that 6 weeks, so we did that by sending home email to parents asking if their child had practiced that day, and then also assessing barriers. So for the first group, we found that on average, children had about 25 days of practice in the possible 42 days over that 6 weeks. And so that ended up equaling to about 4 days a week that they practiced yoga. And in looking at what barriers were to practicing, the most common barrier was not enough time. So this is getting into the results from the study. This is the ADHD rating scale. So overall, for both parent and teacher rating scales, we didn't find significant differences. But when we look specifically at the parent-reported inattention subscale, which is shown here, we noticed that, and I'll just orient you a little bit. So the green squares are the waitlist group, and the green triangles are the waitlist, and the red squares are the yoga group. And so on this side here, this is at baseline. And so you can see that there's not significant differences between the group, but the yoga group has a slightly higher mean score on the inattentive subscale. And after yoga, so this is at post-test 1, the yoga group's mean scores improved, while the waitlist group scores stayed relatively stable. And again, they weren't significantly different, but that was interesting for us to notice. And we saw similar findings for the strengths and difficulties. So overall, on all of the subscales, we didn't find significant differences on the parent and teacher rated scales, but when we looked at the parent rated ADHD subscale, we found that at baseline, the mean scores for the yoga group were higher, not significantly, but higher. And after doing yoga, that group's mean scores improved, while the waitlist group stayed relatively the same, which is what you would expect. So we did some regression models to look at this a little bit further, and we found, and so I'll first just orient you to the graph. So on the x-axis is the baseline scores for both of those subscales. On the y-axis are the post-test 1 scores. And again, the yoga group is in the red squares, and the waitlist group is in the green triangles. And so overall, when we looked at these models, we found that children with higher baseline scores, on average, had improvement with yoga compared to the waitlist, who had a slope of about 1. So for example, this child had a score of about 12 at baseline, and then after yoga, their score improved to about a 4. Similarly, on the strengths and difficulties questionnaire, at baseline, this was about a 7, and then improved to about a 3. So that was really interesting for us to notice. In terms of heart rate variability, we looked at multiple different components of heart rate variability, both in the frequency domain and in the time domain, and overall we didn't find differences between the groups for heart rate variability. And then lastly, the key tap, so that computer-based task of attention. And just before I go into the results for that, it's important to note that at baseline, both the preschoolers and myself had a bit of a learning curve with this task. So in order to, so when we administered the task, they had 3 practice tests, and they had to get more correct than errors or omissions in order to go on to the full test. And at baseline, many of the children in both groups were not able to go on to the full test. And so we didn't have enough data at baseline to use that to control for the results. So what I'm going to show you next is just looking at the post-test one after the first group did yoga. So despite that, we did have some interesting findings. We found that the yoga group had faster median reaction times on correct responses on the go, no-go task, and there were similar trends in 2 other tasks for faster reaction times. We also found that children in the yoga group had fewer errors on one of the subtests, the distractibility subtest. So overall, just thinking about challenges and limitations, it definitely was a small sample size, so it did limit our power. And as I mentioned with the key tap, especially at baseline, there were some missing data. There were a few kids that refused to wear the heart rate monitor, so we weren't able to capture their data. And then there were a few parents and teachers that either didn't return questionnaires or didn't complete them fully. And then overall, the intervention period of 6 weeks was relatively short. So in summary, we didn't find significant changes on parent and teacher rating scales, although there was that suggestion that for children with higher scores at baseline that could be improvement. And in terms of the attention tasks, we did find some significant differences between the groups. Heart rate variability didn't bear out in this study, and I didn't get a chance to go over the qualitative data that we collected, but overall, based on that, on the interviews and rating, the questionnaires and focus groups, we found that the yoga was feasible and well-liked. So in terms of future directions, we definitely need larger studies that can help to answer some of the questions raised by this study. So some of those include, are there certain subgroups that respond better to yoga? Is it the children with higher symptoms that will respond better? Is it a certain type of ADHD symptom that will respond better? Is it more the inattentive symptoms versus the hyperactive impulsive symptoms? And if we did the intervention for a longer period of time, would that help to show more significant differences on the other measures such as heart rate variability? So I also have many people to thank. This study took a lot of effort from many people, and I'm very grateful to everyone that was involved in the study, and I won't go through everyone, but just thank you to all of these people, as well as to all of my mentors, both in my Scholastic Oversight Committee, all of the amazing attendings and people that we work with in our developmental, behavioral, pediatric section, my co-fellows. I've learned so much from all of you, and will take that with me. And the statistical support I got also was amazing.
So again, my name is Alyssa, and I'm a doctoral student in the School of Education at UC Davis, and a LEN trainee. So before I start, I just want to make sure that I acknowledge the Reading and Academic Development Center, which is where I've been completing my clinical training for the LEN program. And so the RAD Center was founded in 2015 as sort of a hub for both research and intervention services for kids who are struggling with reading, including kids with autism spectrum disorder. So my work today is actually focusing in on one particular project, which is the Autism Intervention in Reading, or AIR project, which was a pilot study funded by a private donation in 2015. So just to give you some background on why we conducted this study, it's really important to talk about the reading challenges that we often see in students with autism. So we know that a lot of kids with autism are able to read or decode fluently and accurately, but many of these kids are struggling in the area of comprehension. And so why is that? Well, what we also know is that there's evidence that oral language ability is a really strong predictor of later reading comprehension ability. And we also know that kids with ASD are really struggling in terms of, often struggle in terms of their oral language abilities. And another thing that we have to consider is the social cognitive difficulties that we often see in kids with ASD. And that's really important because we ask kids to read these highly social narrative texts. And to understand what's going on in those texts, you also have to be able to follow different characters' thoughts and emotions, and also be able to predict social events that are going to be happening in the text. So interventions that are targeting these oral language difficulties may be key for improving reading comprehension outcomes for these students. So one aspect of oral language that I decided to focus on was narrative ability. And so narrative language is an indicator of this discourse level oral proficiency. And again, it really requires the interpretation of others' thoughts and emotions. You also have to have an understanding of conflict and how to resolve those conflicts. And you also need to be able to follow a causal chain of events in a story. We know that narrative ability is crucial for communicative competence, again, because our social interactions really rely on that oral presentation of different related events, and we also have to be able to extract all of the relevant points of a conversation. It's also crucial for academic success, in part because educators often use narratives as a way to communicate information in the classroom and to teach content. And again, on the reading side, there's evidence of an association between early narrative abilities and later reading comprehension outcomes, which again is highlighting the importance of oral language. So the particular aspect of narrative ability that I was focusing on is what is known as narrative evaluation. So we can define that as the means by which a narrator may communicate character perspective, references to physical and internal states of the characters, and also character speech. And the role of these is really for the narrator to signal the significance of particular information in a text to the listener. So there's an association between the use of these evaluative strategies and reading comprehension outcomes, but there's also evidence that using these narrative evaluation or abilities in this narrative evaluation may actually contribute to more generalized social outcomes for kids with ASD. So it's an important area to think about when we're considering students from this population. So again, in terms of the pilot study, this pilot study had 2 cohorts, each with 8 participants that had a confirmed diagnosis of ASD. In cohort 2, we had 1 participant drop out, so we had a total of 15 students. And I just want to draw your attention to a couple of things here. First of all, the age range is pretty large for such a small sample. So our youngest child was 7 and our oldest was 12. And the other thing to think about is that this sample overall had lower IQ, and we see that in both performance IQ and verbal IQ scores. So again, this is a pilot study of an intervention that was developed by Dr. Emily Solari and her colleagues in Houston and funded through an IES grant. And the curriculum is called Building Vocabulary and Early Reading Strategies, but we affectionately know it as the Eager Beavers curriculum. So this is just a really brief overview of what we did. So students received 8 weeks of intervention, 3 times a week for 45-minute sessions. Each session, students received targeted instruction in listening comprehension, vocabulary, as well as writing. The instruction in the curriculum is really direct and explicit, and it follows a particular scope and sequence that I'll talk about in a second. We included hand signals for each comprehension skill to promote retention of the skill. And all of the instruction is based around actual children's books. So the books for this curriculum were not designed for the curriculum. They're books that you could pick up in your library or at the bookstore. So this is what a lesson would look like. So it starts with the listening comprehension lesson. And that includes, it uses the before, during, and after prompting model. So students were asked guiding questions before listening to the book being read, and then had to answer those questions after. And there were also targeted questions during reading to promote use of that comprehension skill. In terms of vocabulary instruction, we had target words with child-friendly definitions, and we included vocabulary activities and vocab logs, again, to aid retention of those words. And each lesson ended with a writing piece, which used modeling and independent practice to move students from this idea of planning their writing to really producing written text, and also included some strategies in terms of editing writing. So again, the scope and sequence was developed by Dr. Solari and her colleagues, and there's actually 7 skills in this sequence, but because we only had 8 weeks, we only focused on the first 2. So the first skill was direct recall, which is that idea of, what did I hear right in the book? What does it say right in the text of the story? And then we also were able to get to the skill of making connections, which is that idea of, does this remind me of something that's in my background knowledge, or how can I make connections to what's happening in the story right now? So again, very brief overview, and I'd be happy to talk more about that, but I want to make sure that I get to my analyses, which actually focused on a task that was given prior to the intervention and post-intervention, and that is a narrative generation task, also known as the frog story task. So again, pre and post-intervention, and it used one of 3 wordless picture books, and participants were given different books at pre and post-test. So one of those books at pre, one of those books at post. So participants were asked to look through the pictures one time to become familiar with the story, and then following that, the experimenters simply said, tell me a story based on the pictures, and try to make your story as long as you can. So the things that I was looking for here, again, bringing it back to that idea of narrative evaluation. So there were 4 characteristics that I was looking for. The first, again, is emotional and cognitive states. So that's an example would be, the frog was upset, or the boy wondered where the frog went. And these are really important because they help the narrator communicate what the characters are thinking and feeling, and they also help to elaborate on the motivation behind what's happening in the story. The second characteristic is hedges, so something like, I think the frog is hiding, or it looks like he's all wet. So these indicate narrator uncertainty, and so they suggest that there are multiple interpretations of what's happening in the story. And then these last 2 are really what's known as more of sort of this performance evaluation techniques. So the first is character speech and sound effects, which is exactly what it sounds like. So, splash, the frog went in the water, or the use of a character voice. And then also intensifiers or attention getters, so something like, look at that, or the frog jumped really, really high. So, this use of sort of exaggerating or stressing word is really directing the listener's attention to a particular event or a particular moment in the text. So in terms of coding these narratives, all of the child narratives were video recorded and then later transcribed, and they were coded using a scheme developed by Capps, Losh, and Thurber. It included frequency counts of these evaluative statements. And then in order to control for the different length of the stories, we used propositions, which we can define as a verb and its arguments. So he wanted to go home is one proposition, whereas the boy fell down and the frog was mad are 2 different propositions. So narrative evaluation was analyzed as a proportion. So the number of evaluative statements over story length equaled the frequency of evaluative statements. So basically, out of the child's whole story, how much of it included these evaluative characteristics. So what did we find? So each of the lines represents an individual child. And then on the y-axis, again, we have the proportion of evaluative statements. So, what proportion of the child's generated narrative included these evaluative statements. And so you can see here a couple of the kids did show a decline, but overall, we have an upward trend, which is really promising. So in particular, we're seeing a couple of interesting things here. So overall, at post-test, kids' stories were shorter, but they included more evaluative statements. And so, basically they're saying less, but what they're saying is more thoughtful in terms of considering the perspective of characters or in bringing the listener's attention to a specific moment in the text. And in terms of the individual characteristics, we see an increase at post-test in the references to an emotional or cognitive state of the characters, and also in the use of intensifiers or attention getters. So these are, small but significant results, but they're really interesting when we're considering kids with ASD, because we know that kids with autism have difficulty in understanding others' emotions, and they also have difficulty in engaging in those joint attention tasks, like a shared book reading experience. So I think this is some really promising data that shows that we can actually intervene in these areas. So some more broad implications here. So again, we saw overall pre-post gains in narrative ability, specifically certain narrative evaluative characteristics, after a really brief intervention, just 8-week pilot study. And so again, we know narrative discourse and narrative understanding are crucial aspects of oral language development, which is an especially salient issue when considering kids with ASD, who we know are at risk for these oral language difficulties. We also know that oral language plays a significant role in reading comprehension outcomes. So that's why it's really important to consider this link between a child's narrative ability and later reading outcomes, particularly for the area in the area of comprehension. And I also just want to mention that this is really underscoring the importance of interdisciplinary collaboration. Language, reading, and social needs of these students, they're not isolated. So we really need to be engaging educators, speech and language pathologists, clinicians, caregivers to really think about the different needs of these students. So in terms of next steps, at the RAD Center, we were actually able to get some grant funding to test the Eager Beavers curriculum as an RCT in schools. And so this study went longer, so we were actually able to cover more of the comprehension skills. And we're currently in the process of analyzing those data. And in terms of considerations for future research studies, I think these data suggest that this intervention may be impacting some aspects of social cognition. So I think it's really important to consider the role of social cog in making adaptations to this curriculum. It's also important to consider scaffolding social interactions between participants to really, again, bolster not only social cognitive development, but also social communication. I think it would be helpful to develop more visual supports and create active roles for the students to support engagement. And again, highlighting that interdisciplinary approach to treatment for children with ASD, I think we really need clinicians, families, and educators working together to concurrently address both the academic and the social needs of these students. So I just wanted to make sure that I thank all of my mentors for their time and their efforts put into the LEN program this past year. So it's been an incredibly enriching experience, and I really appreciate the chance to be a part of it. So thank you very much. Any questions?
Everybody hear me okay with that? Okay. So thank you, Janice, for that lovely introduction. So as was mentioned, I do work in 2 different facilities, and my focus is a lot on mental health. And so it was interesting to me to develop a project that integrated both sides of my training. And so I've got a lot of background in working with trauma and in working separately with neurodevelopmental disability. And so this project in and of itself came about as a result of trying to integrate both of those areas together in some gaps that I've noticed across settings. And so foundations, so the CDC reports that 1 in 68 children are diagnosed with autism. This is, and we're seeing that there are increases in this number occurring too, where we can see arguably that there are some places saying 1 in 45, and we know that it's an increase that's occurring across our system. And so I also want to define adverse childhood experiences. And so what we also see is that there are there are two-thirds of adults that are reported to have at least one adverse childhood event in their development, with a total of 22% of adults reporting 3 or more adverse childhood events. And so in defining what an adverse childhood event is, that would be victims of crime, exposure to domestic violence, physical, sexual abuse, emotional neglect, also including things like being in a war zone, and then also just major disasters or natural disasters that we see. And so this graphic demonstrates a breakdown nationally of 22.6% of adults across the nation, so 1/5 have at least experienced 2 or more ACEs. In the state of California, we see 18.2%. In Sacramento County, we have 23.6%. And then in Sacramento City proper, we see about 24.4%. So almost a quarter of adults are reporting these experiences. So this is also an epidemic that we're seeing as well. And so for our trauma and developmental disabilities, we also see that children that have a developmental disability are twice as likely to experience emotional neglect, physical and sexual abuse. We also see that they're 3 times as likely to experience domestic violence. And then we also see that they are 4 times as likely to be victims of crime or twice as likely to be bullied. And so they are more susceptible across these two different areas to exposure to these different things and more vulnerable. And so it is of critical need that we integrate these two areas of trauma and ASD, or in developmental disability. And so community mental health settings, we see that they're often funded by Medicaid or Medi-Cal in the state of California. And so in and of itself, that can be, we have a low-income population oftentimes that we're seeing, or children oftentimes that are in foster care or adopted, who are more vulnerable to experiencing ACEs. And then we also see a focus on acute mental health conditions and evidence-based practices within these particular settings as well, due to funding limitations or what they find as best practice for these different conditions that they see. And then we also see the funding for autism treatment in these settings is limited or not existent, or non-existent. And so talking about SPA 14026, so this was a recent law that was passed in the state of California that mandates that behavioral health treatment is incumbent upon the insurer to provide services, including Medi-Cal. However, there's a caveat to that. Behavioral health treatment does not mean mental health services. So that means that these particular community mental health settings do not provide treatment for autism proper. So that would be those places that are contracted through regional centers for ABA or different forms of behavioral health treatment will be funded through their insurance oftentimes, but not in a community mental health setting. And so that has an implication for treatment and training for the clinicians within those settings. And so talking a little bit more about my other site that I work at, the UC Davis CAARE Diagnostic and Treatment Center. So this includes clinicians of many different levels of training and areas of knowledge. So we have clinical social workers, we have marriage and family therapists, we have licensed psychologists, and again, of all different levels of training, graduate students, undergraduate researchers, postdoctoral fellows, and because it is a wonderful training institution. However, the focus is on trauma treatment and evidence-based practices there. So we do focus on parent-child interaction therapy with a particular focus on trauma treatment, provide trauma-focused cognitive behavioral therapy, and then we also focus on dialectical behavioral therapy for some of our older kiddos that we see there. And there are many avenues of funding in addition to Medi-Cal, including grants for research and treatments of specialized populations over there as well. And so the current project, as I mentioned, stems from a curiosity on how to best provide resources and training to staff and clinicians regarding autism and trauma implications. And I wanted to provide a presentation and follow-up information that could be left somewhere that was accessible to the clinicians afterwards regarding the integration of both of these areas. And so I created a specialized presentation for our particular infant mental health team, which is who I particularly work with over there. That will also include developmental milestones and red flags, as well as a referral process for early start services in the state of California. And so just to gauge how successful or how helpful this project may be, I did create a pre-post survey to analyze how my presentation was effective. And what was very nice was the feedback that I received for it. So I did get 23 pre-survey responses, then I received 20 post-survey responses. So that was a nice feedback to get from the clinic itself. And so the survey was very brief. It was 6 questions that I will go through individually here. And they were Likert type responses from a 3 to 5 scale. And so these are the different presentations that I gave. So to the Care Center general staff, which included all of our clinicians, this was about a 30-minute presentation, and it included DSM-5 criteria for autism and PTSD. It also talked about the overlapping and distinct symptoms between. I talked about assessment components for an autism evaluation versus looking through a trauma lens. I also talked about different screeners for autism and development, as well as separately looking at trauma. And then we talked about next steps for developmental concerns in general. And then we talked about treatment recommendations. And then we also talked about considerations for a dual diagnosis and adaptations for use with autism and trauma combined when those presentations did occur. And so for the infant mental health team, I had a little bit more time on my hands and more information to provide to them because they are at that early intervention stage with a 0 to 5 population that they do see. And so their presentation included all of that that's already been covered with the general staff, as well as red flags in early development and talking about what particular areas to focus on when they're seeing these markers in kiddos. And then the process of referral to early start services in California and what that may look like. And so the first question that I asked on my pre-post survey here was, how knowledgeable do you feel about autism spectrum disorder? And so this was on a 1 to 5 scale, 1 being not at all knowledgeable to 5 being a large amount of knowledge. And so what we see here is we have a 3.57, so this is also on a weighted average comparison. And so we see that pre-survey, they're at 3.57, post, they're at 3.95. So there was a small gain that we saw in knowledge of autism proper, and which was nice, and I wasn't anticipating seeing a huge jump because that was not necessarily the focus of the presentation in and of itself. So my second question was, how comfortable do you feel in identifying and diagnosing trauma-related concerns? And so again, thinking this is the focus of this clinic, this should hopefully be on the higher end of things. And so this is a 1 to 4 scale, so 1 being not at all comfortable to 4 being very comfortable. What we saw was a 3.61 pre and a 3.75 post, which is pretty consistent with where we would hope that clinicians that are treating trauma feel comfortable with their trauma-related concerns. And so looking at question 3, how comfortable do you feel with diagnostic differentials and symptom presentations in co-occurring trauma and autism spectrum disorder? This is on a 1 to 5 scale, 1 being very uncomfortable, 5 being very comfortable. And this is where we saw the biggest jump. So our pre-survey looked at a 2.91, so this is hovering between somewhat uncomfortable to neither comfortable nor uncomfortable, jumping to a 4.15 post survey, where it was more to somewhat comfortable to very comfortable in looking at dual diagnosis, which was a very nice result to see. Now, question 4 looked at, are you familiar with available resources for families with autism spectrum disorder? This was 1 to 5, from not at all familiar to very familiar. And the results indicate that they went from a 3.09 to a 3.9. So closer to from aware but not familiar to more relatively familiar. And so what was also presented on that slide, I did have videos of different forms of treatment for autism spectrum disorder as well, and the different areas to go. It wasn't something that was a large focus, but it was provided for them, and we did cover it briefly through there. So this was nice to see. 5th question was, do you wish you had more information on neurodevelopmental disorders? This was on a 1 to 3 scale, so 1 being not at all to 3 being, and so not at all to a little more and a lot more information. And the results indicate that they had wanted closer to a lot more information, where they felt post-survey that there was a little more information would be nice, which we can always benefit from, but it was nice to see that they felt generally comfortable with the information that I had provided for them. And then question 6, how often do you encounter clients and or families impacted by ASD? 1 to 5 scale, so 1 being never, 5 being all the time. And so it was good to see that this stayed relatively consistent across both surveys. And some of these questions were looking at just validity of how the rate of response would occur, and this would be one of those questions. So it was nice to see that that hung together very well. So the overall survey comparisons, just looking across the different questions, there were areas where there was growth pre and for post-survey, and then there were areas where we wanted to see a decline. So question 5 would be an example of where we wanted to see a decline in that they didn't need as many resources. They felt comfortable with the resources that I had provided them. For question 1, 3, and 4, we did want to see that increase of having provided the resources, having some more knowledge about autism spectrum disorder and dual diagnosis. And then for questions 2 and 6, those were more of the validity related questions of how frequently do you see these families walk through your door, and how familiar are you with trauma-related diagnosis? And so it was nice to see that those things hung together very well. So what does this mean? So implications here are that providing information about ASD and trauma-related symptoms show promise for clinicians. Even brief presentations with general information and resources can increase a clinician's reported knowledge or confidence in previously less endorsed areas of practice and referral. And it also piques interest in topics highly relevant to, but little discussed with clinicians' daily work. So neurodevelopment and autism proper is generally not a topic that's spoken about in a setting like this. And it was nice to see that there was a lot of interest in what I brought for them, and that there were lots of follow-up questions, lots of follow-up consultations as a result too. And so it really did pique an interest in something that just wasn't talked about as much, but was very much relevant to their work. And then it provided an avenue of continued learning for them as well. And so there are links now between neurodevelopmental research and work and the community mental health clinicians that's often overlooked and little considered. And so it's nice to see that we can make a bridge for this gap and really create something that is helpful across both settings. And then advocacy and training for mental health clinicians is very helpful for the families that are particularly being affected by these areas, and it's key to bringing families in contact with the needed resources. And so for our future work, we really want to make connections with community mental health settings. As we see a more vulnerable population walking through these doors, we also want to ensure that they're getting the best quality of care that we can, and they are the ones that are most vulnerable, not only because of systemic reasons, but also for funding reasons and being accessibility reasons. And so we really want to make sure that those connections are being made. Regular trainings provided between systems of care are implemented. We really want to make sure that that's a focus, and that's something that we're aware of across the different areas of research that we provide, as well as looking at the work that's being done on ground level. And coordination of care between various systems and rates of contact among various service providers. And I think that would be a great way to follow up and seeing what the rates of provision of these types of services and implementation of adapting certain modalities to dual diagnosis would be really interesting to see, and how families follow up with the resources that are provided to them through their mental health clinicians, and also the advocacy of these clinicians in contacting regional centers, talking to different systems of care for these particular families, and how that incorporates in successive treatment for these families as well. And so that would also be part of it, is just tracking the felt experience of these families in these particular settings. And so that's the work that I did through my particular LEND project. So I really had a lot. I really want to thank everybody that's worked with me and the LEND program itself. I've really felt such a growth this year, and it's been really nice to work with everybody, and I'm gonna miss being here, that I've really enjoyed my time and all that I've learned, and I know that I'll be taking it on with me as I continue in my career. So with that, are there any questions?